Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you'll move to the first update. So HHS, Office of Health Policy, is required to provide an annual impact of the No Surprises Act report. So this first report was just produced, and it's mostly about reporting, starting with a baseline, because the data only goes through 2020. And obviously that was before the No Surprises Act was fully in place, in fact, before it was passed. So it looks at 4 areas, 2 of which are closely related. It looks at the state surprise billing laws that are already in effect and anything about the impact that they can gather about those. And then it looks at market consolidation and concentration, as well as its impact on prices, quality, and spending. And then the part that is probably most interesting in this baseline report is out-of-network billing trends. The consolidation and concentration data that they supply is a little bit difficult to parse, and I decided it wasn't worth trying to come up with some general comments on it, but you can feel free to look at it on your own at that link. What was interesting was that out-of-network billing had been dropping slightly throughout the entire 2010s, and then it jumped up a bit in 2020. And I have no idea if that's pandemic related or not. It doesn't seem like something that necessarily would be, unless all of a sudden there were a whole bunch of new telehealth providers that were out of network. But be that as it may, they took the out-of-network data and actually organized it by type of practice and type of physician. And so that was actually, excuse me, that was probably the most interesting thing in this report. Not surprisingly, mental health services and emergency room services were the 2 highest out-of-network categories. They were like 10 to 12% each, somewhere in that range. Then pathology and pain medicine were at about 6%, and everything else was 4% or less. And there was basically a 2 to 4% lane for hospitalists, for general practitioners, for other specialties. So you can find the full report at the link. Anyone have any comments or thoughts that they'd like to share?
Janice, one of the things that might be driving the higher costs in emergency services and mental health is the increased prevalence of private equity in owning, increasing stakes in those particular areas.
Oh, so you think that the general increase in out-of-network might be due to that? Like people who've gone to like boutiques instead of being in,
or people who go to the emergency room and don't realize that many of the emergency staff are out of network, or they're owned by a third party.
Gotcha.
So the higher fees coming from emergency services has been something that private equity has been guilty of.
That'll be interesting to track then, since No Surprises would make those people have to be treated like they're in network. So that will actually, if we think that's the reason, then this should be good baseline data to make those comparisons in future years. So we'll have to see what comes out of it in future years. But that's a good point, Denny. I also think some of the other things, like the growth in the boutique, I'm not taking any insurance type providers for some primary care and other areas, might also drive some of that in thinking about it. Kind of a related topic, but not the same. Anyone else have any thoughts or comments here? All right, then let's move on to the next update. Apologies. So the White House put out a release announcing a series of executive actions around healthcare, consumer healthcare protections. Some of these you may have heard of because I've seen some of these just in the news generally, but there's sort of three areas that they focused on. One of them was sort of getting rid of junk insurance plans and increasing the transparency requirements, being stricter about what constitutes a short-term insurance plan, and also not allowing fixed indemnity plans to pretend to be health insurance and therefore mislead. So I thought that was interesting. And I think the transparency is the one that they push the most, which makes sense. They also talk about some additional guidance on surprise billing, which I'm guessing is actually the CMS stuff that's on the next slide. And so they talk about providing some more clarity on in-network versus out-of-network, and when surprise billing laws apply. It's possible there are other things that are not what's on the next slide, because the next slide is very specific to one area in that. And then they also call out that facility fees must be treated like other healthcare costs, are subject to NSA, etc. So apparently there's been a trend of trying to get around some of the No Surprises Act and other consumer protections by putting more and more things into facility fees rather than direct treatment fees. And so they're trying to crack down on that. And then the last area is some increased protections on unfair medical debt. And they're focusing a lot of this effort on whether medical credit cards and loans are breaking the law, particularly around the practice of providers signing patients up at the time of encounters. It was one area that they called out in particular as being potentially very problematic. So the Consumer Financial Protection Bureau, I always forget what that stands for, HHS and Treasury have an upcoming RFI related to this. And they didn't specify the timing or exactly what it would cover, but this group of stuff under unfair medical debt. So we'll take a look at that when it comes out. Any questions about sort of these three areas? We'll talk a little bit more about the surprise billing on the next slide, like I said. All right, well, you can find the release. They go into it's very high level, but they do go into more detail than I did about these things if you wanted to take a look at the release. Next slide. So CMS has put out a new fact document for No Surprises. Again, I think this is the guidance that the White House was talking about in the release that was on the previous slide. But they basically have three questions in this new fact set. And the first two are specifically about our ambulance services. So the question was whether air ambulance services have to count towards out-of-pocket maximums, and the answer is yes. And whether air ambulance services with any type of payer contract but who are not officially considered in-network must be considered in-network for the purposes of calculating out-of-pocket maximums. The answer to that is also yes. So I guess they were getting around, they had contracts in place, but they weren't considering them network. And they didn't go into a lot of detail about exactly how that's been working. But again, people get very creative when they want to try to get around certain things, I've learned. And this apparently is one of the ways that that's been happening. And then the last, again, whether facility fees are eligible items and services that qualify for the No Surprises Act, the answer to that is also yes. Each of these three questions has much more verbose answers, and there's some background information provided about why they're addressing the issue, etc. So you can find that document at the link there. But any questions or comments for now? All right, then let's go on to the next slide. So MedPAC, which is the Medicare Payment Advisory Committee, has to provide an annual report to Congress evaluating Medicare payment issues and making some recommendations. So the 2023 report has come out. I have not had it, just so you know, I've not had a chance to read it in full. So this is just sort of the highlights of what it covers, but I probably can't answer a ton of questions about it. But be that as it may, it covers these 10 areas. You can see that they were specifically mandated to do 2 specific reports that may not normally be there. One on the use of telehealth in Medicare, and the other one on evaluating a prototype design for post-acute care payment systems. So those are that last one in particular might be interesting. I'm not sure what that entails. And then the rest of it are, most of the rest of them are fairly straightforward things that we talk about anyway. Post-sale rebates for prescription drugs in Medicare Part D. We'll be talking about the Medicaid analog to that later in this meeting. But drug prices, standardizing Medicare Advantage more. These are all things that have come up in many different contexts. So any comments? I can try to answer anything more, but like I said, I haven't had a chance to read the actual report. All right, then let's go on to the next slide. All right, so this is a 2-slide update, just so you know, that's why there's no link at the bottom. ONC has put out another one of their data briefs. These are always super interesting. So this one is about electronic health reporting in in acute care hospitals. And it's looking at 2022 data, so pretty current data. And it does sometimes it just looks at that data, and sometimes it actually compares it to the 2021 results. So one of the things that they found out is that most acute care hospitals are submitting at least some of their data electronically, some of their public health reporting data electronically. Perhaps not all of it. Some of it may be a little bit hybrid, but in general, most acute care hospitals are doing some type of electronic data exchange with public health. And that using reporting through the EHR is the most common method. Depending on the type of data, anywhere from 62 to 84% of acute care hospitals were using EHRs for reporting. HIEs were being used by 14 to 19% across the different types of reports. But for certain types of reports, most particularly hospital capacity data, which is, I mean, that one was far and away much higher prevalence than any other category. Portals or flat file exchange were still being used. Clinical data registry and public health registry data, which are 2 of the other categories, had fairly high numbers, significantly higher than other categories, but they also had a reasonable amount of automated. So it looks like those are most likely being done in some type of hybrid fashion, or some portion of it's manual and some portion of it's automated. But it's clear that those 2 categories are not predominantly manual like the hospital capacity data is. They're just more manual than the other categories and besides these 3. And the other thing which will surprise absolutely no one is that reporting from small, rural, independent, and critical access hospitals lag behind other hospitals. I'm sure that shocks, like I said, absolutely no one. So before we go on to the second page of this, any questions or comments on the data here?
Well, Janice, we know in Massachusetts that a lot of the registry data for public health is provided via the highway. So there's more automation for that kind of data provision in Massachusetts than might be the case elsewhere.
Yeah, and I suspect that that's scrolled into the HIE category that they have.
Yeah.
But yeah, and there definitely was, like I said, for that category in particular, a fair bit of automated. It was showing both, and in fact, it was both numbers were high enough that there had to be some group of people that were doing both things, because it was not like 70% manual, 30% automated by any stretch. So, all right, well, let's look at the rest of this. Let's go on to the next slide. So this slide talks about the reported challenges that people found in trying to do electronic reporting. So one thing that was interesting was that the challenges were more or less the same across all the different types of reporting. 75% of the hospitals reported at least one challenge. And there were more challenges for clinical data and public health registry data than for other categories. There were fewer, interestingly, and now this is 2022, so it's possible that this is because this is the data that got more attention during the highest points of COVID, but the least barriers were experienced in laboratory data and immunization data. So that probably what happened is that they've made that go more smoothly during the height of COVID, and now it's running more smoothly than other data, is my guess. But in general, the challenges that were reported were the same across all different types of data. The biggest challenges were finding that the public health authorities themselves couldn't receive electronic data that the hospitals wanted to send. And 50% of hospitals said they experienced that. 39% said that the submission process or the technical complexity of the interfaces that the public health folks wanted them to use were a barrier. And onboarding was also highlighted as a major problem. Interestingly, even the least common challenges were still cited about 15% of the time. You'll note that, sorry about my phone if you can hear it, you'll note that that code mapping is actually identified as one of those as a challenge 16% of the time, as is the lack of structured data in the EHR 13% of the time, and the inability to send electronic data 16% of the time. So this, as all of these ONC data briefs are always super interesting. You can find the full report at that link. I highly recommend reading it. But any questions about these barriers and challenges? All right, then let's move on to the next slide. All right, so there is a new proposed rule. Shocking, I know. I have not had a chance to look at it in detail yet. It just came out, but or rather I just found that it actually came out like a week and a half ago. But basically it's on the way that Medicare plans to cover emerging technology. And there is, so my understanding of what I did look at is that there are some suggestions and plans, and then requests for comment on other ideas or thoughts about how well those suggestions would work. So I will be taking a look at that. It's not clear to me whether exactly what's entailed, other than that it only applies, it is for specific novel breakthrough devices that do have FDA approval. So it is not for using stuff that is not yet gone through the full FDA approval process, nor is it for using things that may not be appropriate for the FDA process. Although, as we've seen, what qualifies as a medical device these days is pretty broad. So a lot of the emerging technologies probably would fit under that program. Any questions or comments? All right, let's move on. Here's another thing that came out a couple weeks ago that we just found. The NIST cybersecurity framework profile for genomic data. They've put out an initial draft. I believe it was put out on June 15th. They give 30 days to comment, and it got extended slightly, I think, because of Juneteenth. So the deadline to comment is actually this coming Monday, so we obviously won't be commenting on it. But this is basically, we've talked about the CSF several times before at the DGC. But the idea of this profile is that it's voluntary guidance that helps organizations manage cybersecurity risks. And it usually addresses privacy too, and this one does. And so this is specifically for issues that may come up around genomic data. And it actually, in addition to the actual genomic data itself, it talks about issues around sample collection, sample preparation, the data generation, and data analysis phases. And it also talks out there are 12 different objectives that are listed, and it talks about the methodology that they use and how they made decisions that they made in order to come up with the profile. I have skimmed through it. I haven't looked at it in detail yet, but these tend to be very detailed technical documents that also include business logic. So any comments or thoughts there? Or you can find it at the link at the bottom of the page. Let's move on then. If you'll pause there for a moment. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That address is also on your screen.